Hi, everyone. It's a great pleasure for us to start our seventh episode of the talks in evolving branches in medical gastroenterology. And the first chosen major topic is motility sciences. And the today's topic is Indian standards in high resolution manometry, adapting Chicago classification for water perfused system. And the talk would be given by Dr. M. Srinivas, sir, who is a medical gastroenterologist currently practicing at Gleneagles Hospital, Chennai. Sir has vast experience in motility sciences. I personally have met Sir multiple times in Gleneagles Hospital at Chennai, and Sir has done a lot of work which is more Indianized and has also developed standards for Indian manometry for the population that we generally face. So I think he is the apt person to do justice to this topic, and the entire podium is yours, sir. Pleasure is ours. Thank you for accepting our invitation on a Sunday evening. Thank you, sir.
Good evening, ladies and gentlemen. Thank you, Prashanth and Narayanan, for giving me this opportunity. So, the topic given to me was Indian standards in high resolution esophageal manometry, adapting Chicago classification for water perfused system. So, I am setting the scene for this. See, it is quite common for us to have a patient who complains of dysphagia. His OGD is normal. We do a manometry, which looks like a hypercontractile esophagus, but the DCA is less than 8,000. So since the DCA on at least a couple of times less than 8,000, we are forced to report it as a normal study. But then we always think the patient complaining of dysphagia, it looks like a hypercontractile esophagus, but the DCA was not high enough. So was it really normal? I'm sure many of you have come across this situation when you are all those who are doing manometry when you have reported. So before we go to that, what is esophageal function testing? How do we go about it? See, as you all know, we all do an upper GI endoscopy to assess the structure. That is a must. We must assess the structure before we go to do functional studies. And high resolution esophageal manometry assesses the function of the esophageal body and the lower esophageal sphincter. And a 24-hour pH study assesses the extent of acid exposure, and we do it with impedance. It tells you what type of reflux rate. Is there a reflux rate coming up? Is it acid or non-acid? So what does manometry do? It measures the pressure exerted by the esophageal wall muscles, resulting in motility of luminal contents. The interplay of these pressures in the esophageal body and the LES, lower esophageal sphincter, results in a normal motility or pathology. So this is the principle behind esophageal motility and manometry. So many of you would have used the old system of manometry, and when you actually see, these used to be line tracing, very much like ECG, not easy to follow as soon as you see it. Whereas now you have a beautiful color plot where you have all these nice colors representing different pressures. The blue color is low pressure, green is slightly higher, yellow little higher, shades of pink and red correspondingly showing higher pressure. Black is very high pressure. The comparison between the old system and the new system will tell you how far we have progressed. In the old days, the catheter used to have 5 to 8 sensors. They were water perfused. One needed to do repeated pull through and look at the line tracing and determine whether we are in the near the LES or in the upper sphincter, all those things. The new catheters have sensors ranging anywhere between 16 to 40. They are available as water perfused and solid state. One does not need to keep manipulating during the test. And a color plot as we earlier saw. And most importantly, we have an objective reporting format called the Chicago classification. So as you can see here, the one on the left is the water perfused system, which I'm sure most of you are using. And the other one is a solid state catheter, which is currently becoming more available in India. A few centers have got this system. So what is the difference between water perfusion and solid state catheter? See, the water perfuse system takes time to set up. And I can tell you from personal experience, having put this catheter down myself at least 4 times in the past for doing various studies, you constantly have this feeling of water filling in the throat because water is constantly dripping through the channels. However, the tube is quite soft and flexible, and it does have a very long life if taken care. And the catheter is cheap. It is not very cheap, but compared to solid state, it is cheaper. Whereas the solid state is ready to go. It's like a plug and play, but it is quite hard and thicker and tends to have a shorter half life, shorter life, and much more costlier compared to the water perfused. However, both are autoclavable and impedance varieties are available with both. So manometry with impedance is also available, but we are more familiar in our country with pH impedance. So this is our standard water perfuse catheter, what we all use. So as you know, this contains 16 channels. The high resolution segment is in the lower portion, that is nearer the lower esophageal sphincter, where the 8 sensors are placed radially, that is all around in different places, 1 centimeter apart, and proximally there are 8 sensors placed 3 centimeter apart. That is why this catheter is not ideal to evaluate patients for any upper esophageal sphincter problems like a cricopharyngeal spasm or a bar, all those things. So it is best suited for the mid body, lower esophageal sphincter rather than the upper esophageal region. So for any test, it is always essential to standardize the test and the report. This will facilitate universal, uniform comprehension. So if I tell something, everybody should be able to understand what I am telling. Other than it should not be that I use a different method of reporting or speaking about something and somebody else does. So the test has to be standardized, the reporting has to be standardized. To give you some examples, when we all talk of severity of an upper GI bleed, you talk, this patient had a Rockall score of so much, everybody understands what you are meaning. Same way, when we say esophagitis, we use the Los Angeles classification. I say LAA, you also know what LAA is. If I say LAD, you know LAD. So each of us uses it appropriately. We understand each other. We are speaking in the same language. And same way, clinical grading in IBD, like using the CDAI and various scoring. And also to determine the extent of IBD, we use Montreal classification, stricturizing, non-stricturizing, what is the extent, pancolitis. So all these are standard methods of doing. And for high resolution esophageal manometry, we have the Chicago classification. But every reporting, see, like everything else, every reporting is subjective, depends on how I'm going to grade. For example, Los Angeles classification for esophagitis, if I do not apply grade C as C and just say it is B, if I downstage it because I don't have an understanding of it, then the whole meaning changes. After all, LAA is thought to be occurring even in normal people. B is less common, but C and D are definitely suggestive of severe reflux. So it is important that we are all speaking the same language on the same page. Even though the classification is there, our application has to be similar. And that is where standardizing the whole process is important, starting from doing the test. I always believe that functional studies have to be done by the person who is reporting it. It should not be done by somebody else and somebody else sits in an office and looks at the tracing. Because many a times when a technician does the procedure, the patient may have been anxious, they may be repeatedly following, you don't get good windows, there is a lot of artifacts. So if you sit there, you watch the whole procedure, and you also sometimes in between the procedure, suddenly there may be a segment of TJ pressurization. There may be a segment where it looks like there is some pan pressurization. Then you know that you have to do some other test. So always good to do the procedure, be there in the room, watch the screen while it is being done. So how do we go about doing the test? So step one is record the basal tracing first. How do I do the basal tracing? Ask the patient to take slow, deep breaths, 3 cycles, inspiration, expiration, with no swallows in between. Many times the patient is having difficulty doing it in the beginning because they are apprehensive. I don't worry about that. I complete the procedure, and at the end of the procedure, I ask the patient to do it again. By that time, they have got acclimatized to doing the procedure and they are able to cooperate better. So once we have done that, 10 5 ml water swallows in supine position. And now Chicago 4 recommends doing both postures. So 10 5 ml water swallows in sitting posture. You can do them either way. You can first do 10 swallows sitting, 10 swallows lying. Even before Chicago recommended doing sitting postures, probably for the last 12 years, I have been doing sitting only. Unless I am having some doubt about what is there, I do the patient lying down. Because to me, a physiological position where patient complains is usually in the upright position. Patient come and complain when I'm eating, I'm having difficulty. When I feel like something is sticking, things are not going. They seldom complain about symptoms when they are lying down. When they are lying down, they complain. It is usually they have achalasia. They are getting oronasal regurgitation. So I always do my procedures sitting. And if necessary, I make the patient lie down and do it. Sometimes some patients do not tolerate sitting because of that throat irritation. They are a little bit better lying down, probably because when they are lying down, the catheter falls back naturally along the curve of the spine, so it doesn't irritate that much. And in addition to these things, we have to do the rapid drink challenge, always done sitting, not in lying posture. And sometimes in some patients, you need to do solid bolus. Of course, not to forget the multiple rapid challenge or MRS. So these are the things to do during a procedure. Now coming to how to report, I'm going to spend some time on talking about what are the metrics, where to place the cursor and all that, because like I said in the beginning, in order to standardize what we are talking, if you tell me this patient has DCI about 200, then that means you are putting the cursors the same way that I am putting the cursor. It should not be like you are putting it differently. And if I put the cursor, it will come 500. There can be a difference of 100, but there should not be a difference of 300. Then that whole thing gets distorted. So that is very important. So now you are all familiar with this. This is upper esophageal sphincter. You see on the top, the proximal skeletal esophagus. Then you have a little transition zone. Below that is the smooth muscle divided into segment 2 and segment 3. So this is segment 2, and nearer the ampulla is segment 3. Then you have the lower esophageal sphincter. With deglutition, there is relaxation happening here, and the wave is going forward. So this is our normal esophageal manometry. So what are the metrics in Chicago classification? These are objective measurements. First, we have the integrated relaxation pressure. Then we have the distal latency. And then we have the distal contracted integral. So these are the three. We also used to do peristaltic breaks, but Chicago 4 has done away with the peristaltic break. So what do each of these represent? The distal contractile integral represents the amplitude of the contractions and the duration of the contraction in the esophageal body. The distal latency tells you about how long it takes for the food bolus to traverse the entire esophagus to reach lower esophageal sphincter ampulla. And finally, breaks tell you about coordination of the contractile response. The Chicago has done away with breaks because even there are big breaks, the DCI is going to be lower anyway. So therefore, breaks don't always necessarily require. So if your DCI is low, it indicates there is a big break. And with regard to the lower sphincter, there are two profiles, the static profile and the dynamic profile. The static profile tells you the length of the lower esophageal sphincter and the pressures in the, which is the basal LES pressure. And the dynamic profile tells you of the relaxation properties of the lower esophageal sphincter, which is the integrated relaxation pressure. So we talk about each of these. So integrated relaxation pressure is a measure of LES relaxation. It is a mean of 4 seconds. It may be contiguous or non-contiguous relaxation of maximal deglutitive relaxation in a 10-second window, beginning from the onset of upper esophageal sphincter. So what is normally done is, so here, if you see on the screen, this is the opening. Now you place your cursor here, beginning of swallow. You place your cursor there, and then you would have placed your upper esophageal sphincter, the upper portion of the lower esophageal sphincter cursor here, lower portion of lower esophageal sphincter here. And then your end of analysis will be somewhere there. So what the software will do is, it will take this area and measure 4 continuous or non-continuous seconds of maximal relaxation. That gives you the IRP. This is reference to the gastric pressure, which is low, negative. The final IRP is median of all readings. So we should be doing 10 swallows to get an accurate median. And the unit is millimeter of mercury. So then this important point of contractile deceleration point, or CDP. What is CDP? It is the point at which the esophageal peristalsis slows to reach the ampulla at the lower end of the esophagus. Yes, just like the rectal ampulla, there is also an esophageal ampulla. This receives the food material and tells the LES that, look, food is coming or water is coming, you have to relax. So that is the point of transition. Chicago wants us to report this within 3 centimeters of LES. So how to go about it? You draw a line along the wave, and then you draw an imaginary line from the lower esophageal sphincter which cuts across. And that point is the CDP, or contractile deceleration point. What is the importance of this? This per se is not a metric. This is not important, but its use, its position is important to determine the distal latency. What is distal latency? It is the time taken for the peristaltic front to reach the emptying point or the ampulla. It is a measure of the adequacy of inhibitory neural function. So the interval between upper esophageal sphincter relaxation and this CDP is the distal latency. See, why I am telling all these things is, we have to put the cursor in the relevant places. If we put the cursor in the wrong place, we don't get correct value. Especially for distal latency, if you take the cursor and put it very high up, although Chicago says keep it within 3 centimeters from the LES, when there is a normal peristaltic wave, if you keep it higher up, you will get a distal latency which is short. And erroneously, we will call it as diffuse esophageal spasm. So that is why it is very important to put this cursor at the right place. And thirdly, the distal contractile integral. It tells you the vigor of the peristaltic esophageal peristalsis. It is usually measurement of the greater than 20 millimeter mercury contour. That is this white line. That contour is measured. It is a composite of the contractile pressure in the smooth muscle component of the esophageal contraction. That is segment 2 and 3. It is a measurement of amplitude multiplied by duration by length, and therefore its units are millimeter mercury per second per centimeter. So where do we place the cursor? I generally put it where the transition point is, and put the entire square to cover the entire swallow, almost till the end of the swallow. It doesn't matter because all this is blue. So this will not add much to the pressure. Only this is going to add to the pressure. The problem comes when there are artifacts like heartbeat and all, artificially raises it. In that type of situation, if there is too much artifact in one channel, you turn off that single channel so that the artifact is removed and you measure the DCI. It does not make much of a difference. So this is how you have to measure the DCI, keeping the cursors in this way. Sometimes there may be a little break here. Doesn't matter. Wherever it starts, you put the cursor and take it. Or even if you take it up and put it, if there is a break there, it is not going to add to the composite value. So the value is going to be less. But if there is a break in the lower esophagus, do not exclude it. Include it and bring it right down here. Because even this low value will not add much to that. But you may as well just have a template of how big your square is going to be. The square incorporates your second and third segments. So how do we apply this algorithm? Now that we have put the markers and we have the system has saved all the data that you have generated, we have to apply the algorithm, right? So as we all know, the first version of Chicago classification came in 2009 and the most recent in 2020. 2 members from India were part of this, Dr. Uday Ghoshal and Dr. Shobna Bhatia. We were all very familiar with this version 3. where when you have always we start with IRP. When the IRP is above upper limit of normal and there is no contraction, we immediately talk of achalasia. And we then divide it into 1, 2, 3. And then when the IRP is above upper limit of normal, but there is some contraction available or there is the wave going, then we think about ETJ outflow obstruction. So these were considered to be disorders of ETJ outflow obstruction or major disorder, or they were significant. And then when the IRP was normal, if you had a short DL, you called it as diffuse esophageal spasm. You had a high DCA, it was called, previously we used to divide it as nutcracker, jackhammer. Now the name changed all to hypercontractile esophagus. And lastly, when there is no peristalsis but the IRP is normal, we call it absent contractile. These are major disorders of peristalsis which are not seen in normal people. And then we had a group of patients whose IRP was normal, but their DCA was low in at least 50% of swallows. We call them as ineffective esophageal motility. In addition to that, there was another group of people who had a normal looking DCI, but they had large peristaltic break, greater than 5 centimeters. We call them fragmented peristalsis. These were called as minor disorders of peristalsis, suggestive of impaired clearance, which can be found in healthy people also. And then anything else was thought to be normal. So we got used to this. Then this latest one, when you look at it, it looks very complicated. So many arms, it's almost looking like Ravana, 10 heads, 20 hands. You don't know where to start, how to go. Very simple. We all start with one set of swallows. And if there is abnormal IRP, then you go down the left side, which is all this achalasia. If you've seen all those things and you're not getting an answer, then you go and do the other position. See, they are telling do the other position. See, this doesn't mean you take the catheter out, report and then do it all over. So what I generally do is, when I am doing the procedure, I do one posture, I do the other posture also, so that at the end of it, I'm not confused if I get some abnormality. Because when you look down this other side, irrespective of what you are getting here, they recommend doing in both postures to corroborate that it is consistent, that it is happening in both postures. So therefore, it is important to do both postures. See, in step 1 itself, you see here, when the median IRP is not abnormal, you have to do secondary position also. That is what they are recommending. So we have to do both postures. And when we do not find any abnormalities, any of these things, one has to consider a meal challenge based on symptom. Patient complaining of dysphagia with solid food, we have to consider that we have to ask them to eat something solid and see what happens. Same way here, when we think of ETJ outflow obstruction, previously we used to say maybe achalasia variant, we used to do a barium swallow, CT scan, all those things, look for outside. Now they are suggesting that we do a time barium esophagogram or flip if available. If the time barium is abnormal, then you think of ETJ outflow obstruction, which may be an achalasia variant, where you can offer the patient myotomy. So this is the new algorithm, which is not really new, but just adds a position and also some other maneuvers like a rapid drink challenge and adding solid bone. So what is the difference in this? So ETJ outflow obstruction, when you have elevated IRP, you change position, still elevated, you do an abnormal time barium or flip. Ineffective esophageal motility, where previously we used to say only more than 50% ineffective swallows, now it has become more than 70% ineffective. That is, DCI should be low in at least 70% of swallows, or 50% swallows will be absent contractility, that is failed swallow. Okay, and fragmented peristalsis or the peristaltic breaks have been completely removed. These are the three major changes. In addition to that, we have to do supine and sitting unless you have diagnosed achalasia in the primary position itself. Another important thing, an iteration that was found even in the third version and also in the fourth version is, it states that the normal reference values must be specific by the system, by the posture, by the bolus, and by the ethnicity. So this is very important. While Chicago keeps on giving us all these values and algorithms, if what we are using is not workable with our system, with what position you are doing. Chicago tells us doing sitting, doing lying, but Chicago has not given us sitting posture. So what do we do about that? Chicago tells give solid bolus. Chicago does not tell us what is the values to use. So this is the problem. So the normal values in Chicago classification, just to recapitulate, IRP less than 15, median IRP, the distal latency greater than 4.5, DCI 450 to 8,000. If it is ineffective isomotility, it is 100 to 450. If it is absent peristalsis, less than 100 in 100% solid. These are what we have been given by Chicago. But one must understand that these are done with supine water source, a 36 channel solid state catheter in a Western population. But our main system that we are all using is a 16 channel water perfused system. When you compare, there are many studies which have shown when you compare a water perfused system with a solid state system, there is lower hydrostatic pressures in the water perfused system due to the presence of a liquid interface. So naturally, our pressures in our systems are probably going to be lower than what is being recorded with the solid state catheter and given to us as normal values in the Chicago classification. So we clearly cannot use these above normal values with our system. If you recall in the beginning, I told you about a patient with dysphagia where it looked like a hypercontractile esophagus, but you do not get a DCA greater than 8,000. So therefore, you are forced to report it as normal. So now you understand the relevance of this in that patient. So we do have Indian normative values for high resolution manometry, and this is something that I take pride in telling that for the first time when I was in UK for 13 years, I had never done manometry in the UK. When I came back and joined Global Hospital, my chairman told me that you have to take up this and do. And I started learning and gradually. Then I saw we are using the Chicago classification. We are applying all those values, but yet that is solid state. We do not have normal. I used to keep asking Narayan, but no normal, what is going on? He said, no, sir, nobody has done. So then I kind of got around and decided to do normal values. So all these two studies that you're seeing here were done on 53 healthy volunteers. And I take pride in saying that I was the first volunteer. I put the catheter down myself because if I have to convince my colleagues at work, I have to tell them that I have done it to myself and it was not bad. So I was the first person to do it. I did it on myself. I sat and put it down in front of the screen. I put it down myself and I operated the computer while my technician gave me the water swallows. I laid down and asked someone to press the button when I did the supine. So we did both sitting and supine water swallows in the first instance and reported them as two papers, the supine in neurogastroenterology motility and the sitting in the Journal of Neurogastroenterology and Motility. I split them as two papers simply because putting them together was too big and the information was very important. I won't keep to the suspense. I will show you what we found. So this is a little busy, but not very difficult. This corner, the left corner, has what is the normal values reported by Chicago. You got all those numbers there for IRP, DL, DCA, and the break. I put the break also because we used to use breaks. If you actually see, when we did supine and sitting, both values in IRP were lower than the median value reported in Chicago. So we got 13 lying down, 13.9 sitting up. Same way, the DL does not get affected much. Whereas the DCI, 450 to 8,000 becomes 350 to 4,500 in supine, remains 4,500 in sitting also at the upper limit, but the lower limit drops even further to 150. The break sizes were consistent right across. So we actually see here, compared to Chicago classification, our supine values, because Chicago is in supine, our supine values for IRP and DCI were lower in our system, in our cohort of patients. So now you can understand when I keep telling it looks like a hypercontractile esophagus, but I can't report it because it's not greater than DCI is greater than not greater than 8,000. That is because I will seldom get 8,000. How many of us are getting routinely more than 8,000? It is like Kumbh Mela. We feel very happy when we see a jackhammer esophagus. Whereas when you apply a lower cutoff, you will probably get more values. This is probably a more appropriate cutoff. And when we compare the supine with sitting, the IRP is higher and the DCI is lower. I'm not surprised by that. Simply because when the patient is sitting, the bolus has to give a little more pressure because more has to come in, will come into the ampulla faster and stay there and push. So the IRP is a little higher in sitting. Whereas the DCA will be less vigorous because there is support of the gravity for the fluid to come down. So therefore, the DCA in sitting posture is lesser compared to supine, whereas the IRP is a little higher because the LES figures that there is a lot of liquid coming, so it lets it go a little slower. So that is why we got these differences. And this is by and large similar to what is being found in the literature in other studies. So now coming to the pathology, we are all interested in only in diseases, not normal. No? So to call someone achalasia, to do water swallows in supine, the median IRP should be greater than 13. The sitting IRP should be greater than 13.9. In my experience, I find most of the time it is comfortably higher than that to get 18, 20, all those things. There are some tricky situations where patient has long-standing type 1 achalasia, where the IRP will be lower and you get confused with an absent contractility. That is where probably this helps. But studies do recommend even using a cutoff of 10 in the appropriate setting. Now, the interesting bit is in this ineffective esophageal motility, absent contractility. Unlike the Chicago classification, which says 100 to 450 is ineffective, less than 100 to 450 is ineffective esophageal motility, we have got 70 to 350 in supine, 30 to 115 in sitting. And absent contractility, therefore, less than 70, less than 30. So these are very low numbers. Actually, if you look at Chicago also, absent contractility is not always nearer 100, it is more near 20. So we are getting these values which we can call as abnormal in our patients. So we did not stop there. Chicago 4 came, we proceeded to go further and look at solid bolus also. So what I used was mini idlis and compared with water. I had 38 volunteers, 18 men, and again, I was the first person to do it. And all of them were done in sitting posture. All metrics we found were higher with the solid bolus. So it's not surprising. The IRP was 21.3. The DL only 0.1 second higher, so 4.6. The DCA was much higher at 500 to 5,900. So now with these values, I give to you the entire spectrum of Indian cutoffs with 16 channel water perfuse system. If you actually see, we have now supine water swallows, sitting water swallows, and sitting solid bolus, mini idlis. I also found that 10 mini idlis is roughly equal to 1.5 standard idli. So if you can cut up, patient does not have those mini trays. They bring the standard tray. They have only standard tray, no problem. They can bring 2 idlis. You cut up 1.5 idlis into almost equal small bits, and ask the patient to take one piece, chew nicely, swallow. When they swallow, you press the cursor for the swallow, and do that. No chutney, sambar, all those things. It has to be dry swallow. So this is what we got in terms of values. I think Narayanan and his team have actually got a printout of this. They have got one nice table, which I would suggest all of you get when their engineer comes to your site and put it in your manometry room so that you can use these. By all means, you want to report by Chicago, you report, but also apply these in your report and put by Indian cutoffs. This is our value using the Chicago. So that over a period of time, you will see that these Indian values are more nearer what is appropriate for the patient context. Now I have a couple of slides for any surgeons who may be there. So we all do what is called as a test for the peristaltic reserve. So it is done in subjects with ineffective esophageal motility by Chicago classification. What is peristaltic reserve? The distal contractile integral ratio of the summative wave after 5 2 ml rapid water swallows done within 10 seconds. So you see here the first one is a normal swallow. Here the patient drinks 2 ml, swallows second 2 ml, swallows third 2 ml, swallows fourth 2 ml and fifth 2 ml. And then you had a declinative infusion here, no wave, but finally there is a summative large wave. That is called the MRS-DC. So this value you divide by the mean DCI of the 10 5 ml water swallow. A ratio more than 0.8 indicates good peristaltic reserve. What is the importance of this? A low reserve means there is a very high risk of post-surgery, post-fundoplication, post-anti-reflux surgery dysphagia. Therefore, the surgeon has to be careful when they are going to do a wrap for that patient. Additionally, in some patients where I have little doubt about achalasia, I find when they do this multiple rapid swallows, you get pressurization. So that is another use of this multiple rapid swallow. I tend to do MRS even in patients who have a normal manometry. So going on further for our surgeons, we did not talk about any pH metry here. So usually patients with hiatus hernia and GRD, surgeons are interested in operating. So what I would suggest to them is a manometry with the 24-hour pH helps to decide need for surgery and the extent of RAM. If the patient does not have severe esophagitis in the form of grade C or grade D at OGD, a 24-hour pH metry of treatment is mandatory. So how to go about it? On manometry, the patient's LES pressure is normal. This is scenario 1. And we've done the Chicago classification, which is normal. We do not do a peristaltic reserve when it is normal. And endoscopy 24-hour pH normal, no surgery. Endoscopy or pH metry abnormal, you try medical treatment first. Next, when the patient has PGJ outflow obstruction and when the pH is normal, you go for medical treatment first. But if pH is abnormal, definitely surgery. When the patient has ineffective motility, esophageal motility with a normal peristaltic reserve and the OGT or 24-hour pH abnormal, definitely surgery. Whereas when the patient has a low peristaltic reserve with a normal 24-hour pH, be very careful. Do not offer surgery in that situation because the patient has no significant acid reflux and the reserve is low. You go and operate on this patient, you may end up with a lot of dysphagia. Whereas when the patient has an abnormal 24-hour pH with a low peristaltic reserve, proceed with surgery, but be cautious in doing the wrap. Do a partial wrap, warn the patient about possibility of some dysphagia after the operation. Stick to a low residue diet, not much solid bolus for a little longer period. The other scenario where the lower esophageal sphincter pressure is low on endoscopy, low on manometry. Here in this situation, I would like to tell you, I do not believe in reporting a lax LES because lower esophageal sphincter pressure is best analyzed in physiological conditions while doing a manometry basal pressure. Because when we are doing endoscopy, we are putting air. The air is in the stomach, air is in the esophagus. Natural tendency for the LES to relax. Some LES will relax more, some LES will relax less. That does not mean that this patient has a hypotensive LES and needs an operation. So I generally do not report a lax LES unless there is a hiatus hernia. So in this situation, you actually see the previous slide. Here we had medical treatment. This is the LES pressure is low on manometry. The 24-hour pH is also abnormal. There I would advocate surgery. When there is EGJ outflow obstruction with a low LES pressure, even if the 24-hour pH metry is normal, you consider surgery, especially if there is a hiatus hernia. And no questions asked. If 24-hour pH is abnormal with a low LES pressure, you go ahead and do an operation. And In the presence of IEM, this remains the same, and this you do not go and operate on a patient just because his LES pressure is low when his Chicago classification shows an ineffective esophageal motility and a low peristaltic reserve in the presence of a normal 24-hour pH. Do not operate on that patient. And the last one is where the pH is also abnormal, LES pressure is also low, definitely consider surgery, but a partial one. So I thought I should add these slides, even though it is not part of the manometry talk, in case surgeons are there, how we can help them in deciding on how to go about surgery. The surgeons who refer to me swear by the manometry and pH. If I say it is all normal, they do not operate. I tell the patient and they also talk to the patient, they are on the same page. So I seldom receive referrals from surgeons with patients who had a fundoplication or an anti-reflux surgery after operation coming with complaints. So it generally doesn't happen because they approach me and do this manometry and 24-hour pH before they go and operate. So in summary, esophageal manometry is useful if it is done properly, analyzed systematically, and reported appropriately. So one has to be there, do all the maneuvers, no shortcuts. Don't do 5 swallows and say that oh, it looks normal, so I will stop there, because all you need is 20% hypercontractile to call it as hypercontractile. So do not cut short. Complete the procedure, analyze systematically, put the cursors in the appropriate places. Even if you're using automatic software, please make sure they are in the right place and report it appropriately using the appropriate cutoff. The Chicago classification cutoffs are based on solid state catheter in supine position using water swallows. Wrong reports, you will get wrong reports when applied in the water perfused system and while doing sitting. So use Indian normative cutoffs by posture and bolus type to get appropriate results. Thank you.
Thank you, sir. Very informative talk. A lot of knowledge from an Indian standards perspective, also how important and how our indigenous values differ quite a lot from the Western data. Uh, am I audible, sir?
Yes, very much.
Thank you, sir. Very useful talk. And lot of points were also included on how a manometry and how the results of it in turn also dictates a surgeon on when to do a thing, how much to do a thing, and when not to do at all. So most of us are quite, we know that if there is aperistalsis or something really obvious, not to go ahead with the surgery. But then the importance of peristaltic reserve being slightly low, then the wrap should be slightly weak or better off not to do a procedure is something which is again a point to be taken from the talk. And irrespective of how many ever endoscopies we do, lax LES is generally a part of our report, because while going it looks okay, while we do a retroflexion there is lax LES. Sometimes it is grade 1, sometimes it is grade 3, grade 4. Okay, it is quite obvious. I'm not even sure if that is also normal when the air becomes actually quite high. If you have done all the way till D3, come back again carefully, and the air that we have put, maybe it is also going and it's a normal response by itself. So this lax ileus is a point which we really have to take with a pinch of salt. How much of this lax ileus is actually a problem, and which are with our new endoscopic intervention of ARMA coming in place. Where do we do ARMA? Is it actually equivalent to a partial fundoplication? A lot of questions were just generated when the talk was going on, sir. So one question, sir, like lit lax ileus, how much importance do you give to the that report, or do you go ahead with the symptoms 24-hour pH metry and then decide? Hiatus hernia also, did you feel that Indian patients the 3 centimeter cutoff is the one useful, or actually our data is slightly different? Just out of interest, sir.
So see, when you do the retroflexion, what we call as the Hill's grading is not a marker of lax LES. It is more a marker of how much hiatus is there. So we should not use Hill's grading as a mark of lax LES. The Hill's grading is a mark of how much hiatus. That is more something that has come into a medical gastroenterologist armamentarium because surgeons like it. So what I generally tend to do is, in order to measure the length of the hiatus, I do not do it when I'm going in. I always do it when I'm withdrawing. When I come out of the stomach, I decompress, and as I come out, I see where is the pinch at the diaphragm, and also where is the squamocolumnar junction, and I measure. At that point, two measurements I will get. Many times it will be same place. A lot of other times it will be two numbers. If your two numbers are within 2 centimeters, I do not report it as a hiatus only. I take 2 centimeters as a cross. That is what I've been doing from my time in the UK. So we always reported it as 2 centimeters is physiological. It is to do with respiration. And actually, I find when patients have had a endoscopy done by our people or outside, and they come for manometry, they are building it up saying hiatus hernia, this, that, and then when you come and do, you do not see a hiatus on manometry at all. Of course, there is a situation where you will not see a hiatus on manometry when the hiatus is very big and your manometry catheter has not crossed the other side. That is one situation where you can get no hiatus in manometry. But that is very, very uncommon. If someone tells me the patient has a 5 centimeter hiatus, I try to go as far down as possible with the catheter to at least see whether I can see a hiatus there before pulling back.
Uh, Great, sir. Thank you. So we have a question by Dr. Srikanth Reddy. His question is there any difference in type 3 achalasia and DES apart from high IRP?
No, type 3 achalasia, you will see in type 3 achalasia, yes, there is a high IRP. There will be only a peristaltic remnant. It is not a full peristalsis. Whereas in diffuse esophageal spasm, there will be a peristalsis with a normal IRP. So that is the difference between them. So see, people are now telling that a hypercontractile esophagus becomes DES and then progresses to type 3, type 2, and then eventually when the patient has been like Mother Earth and put up with all the problems and comes to you very late, you see a big gigantic esophagus. So it is all part of the continuum. This is like, I can say, it is like your NAFLD. Everyone who has steatosis does not become steatohepatitis. And everyone who has steatohepatitis does not become fibrotic. And everyone who became fibrotic does not become cirrhotic. So it is like that. So there is probably a kind of gradual upgradation in this process, which probably starts from somewhere at the level of the hypercontractile esophagus or diffuse esophageal spasm and moves upwards. So that is the difference between the two.
Okay, sir. Cool. Sir, of late, with achalasia, many patients are going towards poem as a solution. Where do you place medical management, pneumatic dilatation, and if a manometry helps with the length of myotomy? Now, that is asked like how much should be the approximate length based on the type, or is there any manometric idea of how to decipher the length of myotomy that is necessary?
See, nowadays, poem can be done in almost anybody. In our center, my colleague Dr. Mahadevan does poems. We have done poems in 70 plus. We've done poems in 20s. So the age is not something that is a problem. Also, we've done poems in people who have had previous failed myotomy, laparoscopic myotomy. Poem has been done. In some other situations where 3-4 balloon dilatations have been done, they have not been effective. You've done myotomy. But all those situations very tricky, difficult, too much scar. And where the procedure will take 1.5 hours, takes 3 hours, 3.5 hours, and you may not get good results. So, as per the New England Journal paper, which has so far not been refuted by any subsequent evidence, type 2, anything works, starting from balloon dilatation. But then my point is, when you know there is a disease process and the patient is reasonably fit and well, why do you want to go and do this type of a procedure where you know it may not work permanently for a long period of time? I'm not telling that surgical myotomy or an endoscopic myotomy will work lifelong or anything like that, but they have better chance because you're
Durable.
going cutting the muscles. So I feel that this situation nowadays, as far as possible, we should be offering a proper myotomy rather than balloon, because I know many individual practitioners feel they want to keep the patient. They do the myotomy. It used to be gold standard, but now it is no longer the gold standard. So we should not do that. They will be doing, always think, what will I do to me or my close family? They have this problem. Then we will all know what we want to do. That is number
Ex-
one. Number two is, usually the length of the myotomy is not a problem. Where it is an important issue is when you have type 3 achilles. In type 3 achalasia, poem is superior to laparoscopic myotomy, because with laparoscopic myotomy, you cannot reach high up, whereas a poem can start much higher. So that is where manometry is very important to typify the the type of achalasia. See, if you have a large esophagus which is very presbyopic, all these procedures may not be useful. The patient may be better off going directly for a esophagectomy rather than trying to do all these things. So their type 1 achalasia may be esophagectomy, especially the presbyopic esophagus. Type 2, we say all of them work well, but I think a surgical or endoscopic myotomy, and definitely type 3 poem with a myotomy done a little, starting a little higher up rather than nearer the LES.
Any other?
I
Nice,
thought
sir.
someone was asking about coiling.
Yes, sir. I'll just see the question. The question is there any specific measures to prevent coiling of catheter in achalasia while placing probe? Uh, that's the
Right.
question, sir.
So yes, there are some things that you can do. I generally prefer in patients. I generally like to do the procedure on the same day or within 1 or 2 days after they've had their endoscopy, because then the endoscope has dilated the lower esophageal sphincter. So it will make it easier for me to get the catheter down. That is number one. Number two is, like I told you in the beginning, I always do my procedure sitting. So most of the time with gravity it goes down, but occasionally I have problems. In that situation, I make the patient lie. I make them lie on their back and try to get it down. If it doesn't happen, I make them lie on the right lateral, so that when they turn on the right side, the hiatus is up. So the esophagus and the stomach become a straight line. So coiling can be a little less because it has to come down and drop. So the gravity in the stomach helps me. And also sometimes I try to lightly, a little bit wiggle the catheter, one direction, the other direction, so that it passes. Very rarely, maybe I can think of 3 occasions in this 14, 13, 14 years where I'm not able to pass the catheter beyond the LES. First and foremost, be honest. Just because they've sent you suspecting achalasia and you couldn't get the catheter down, I do not generally take the patient to endoscopy room, pull it, push it, all those things, because this whole thing is attached to this machine with all these channels attached to it. So therefore, I do not do all that. Or I have to bring the machine to the room, then I have to go and put it down. Once you put it down, when you pull the scope out, there is always a chance this can move back. I generally don't do these things. So if I have not crossed, I put in my report, could not cross despite making so many attempts with different maneuvers. And the patient is your witness. Patient will go and tell, Sir tried so many times, different things he made me do, except standing upside down. So that is number two. Number three, even if your catheter is only in the esophagus, what you want to show? You want to show there is aperistalsis. You want to show there is pan pressurization. If you got these two things, it is no other disease. So what I generally then do is I keep the catheter wherever it is, make sure there is no coil, keep it straight, and start doing the test. As I keep giving the water builds up, I get pressurization. If I don't get pressurization, even after that, I'm not happy. I ask them to drink 200 ml glass of water with a straw. Definitely, you will get pressurization. You report your study. Catheter did not cross despite maneuvers. Procedure done with catheter in esophagus. IRP not determined for that reason. With 10 into 5 ml water swallows and rapid drink challenge, pan pressurization with aperistalsis noted. Features are consistent with type 2.
Okay, great, sir. Sir, one add-on to this question. Many times the catheter will pass. We'll start recording. Patient keeps swallowing despite waiting for some time within the 30 second frame. Like they tend to keep swallowing despite we tell them no stop, no stop. So, is there any tricks? Some of them say trying to protrude the tongue, they cannot swallow while they are protruding their tongue and all. I'm not really sure whether it's a good trick, but then I would want your expert's opinion on how to prevent them, especially basal. We need that significant time of no swallow at all. Now, I have found many times the procedure is prolonged just to get that proper basal data. How to go about this, sir?
Like I told you during the talk, if you cannot get your basal in the beginning, don't worry. You do your swallows. By the time the patient got acclimatized to this, at the end, you make them do the basal swallows. Okay, that is number one. Number two is you don't need 30 seconds. You only need the peristaltic wave to pass. Once the peristaltic wave passes, you can ask them to do the next swallow. So I generally, my time frame from one to next swallow is usually less than 15 seconds.
Okay.
Because what are you measuring? Beginning of swallow to end of swallow. Once the summative wave in the lower esophageal sphincter finishes and I get a little low pressure, I tell them to do the next one. And always try to keep a rhythm. Patients are anticipating. If you get a rhythm for them, no, this is like doing music. The rhythm has to be there. If you do beat of 8 counts, means every 8 beat you have to do what you're supposed to do, right? So they get used to it. So every 15 seconds means they get used to it. By the second or third swallow, do not hesitate to do more than 10 swallows. If you're not got good swallows, second, third swallow, not good, fifth swallow, patient coughed, don't hesitate to do extra swallows. Always good to get 10 good swallows rather than making do with some not very good swallows. Also, when the patient didn't cooperate with you, you tell him this swallow is not counted. So then they know. And I laugh and tell to them, look, the more swallows you don't cooperate, the more we will be sitting here. It is no problem for me. I can sit here till evening, but you are the one having the catheter down your throat, so just think about it. So they might see it is not very difficult. It is just the feeling of something. I do so many patients who are on lung transplant workup. They all come and do their manometry. They are on 6 liters, 10 liters oxygen. So it is just getting the mind under control and doing.
Great, sir. Always as jovial as you always are. So next, Dr. Naganath Vodayar has a question. He has asked, sir, explain the concept of compartmentalized esophageal pressurization contributing to diagnosis of achalasia type 2. And
So
he also adds a question, does Chicago 4 is applicable for diagnosing post-fundoplication dysphagia? Two questions from him.
see, none of these, I'll take the second one. None of these are for post-operative. If you have a pre-operative, that is why pre-operative important. If you've done a pre-operative manometry, you do a post-operative manometry, then you can compare. But per se, post-operative value you are getting, of course, if that IRP was patient complaints of dysphagia and you have an IRP that is 30, that's clearly abnormal. But there are no values as such for post-operative pain. Even for achalasia post-operative, there are no specific values. You compare with pre and then report. Like you do the Eckhart score, pre and post. It's like that. That is number one. Now, this compartmentalized pressurization is one segment is showing high pressure. Okay. So mostly it will be in the lower portion. Okay. So EGJ, and just above that, there will be a wave trying to cross, trying to push, but it is not able to push. So all that pressure comes and forms a wide area. You think about this jackhammer esophagus, which is much bigger. This is a smaller one, right? Instead of a jackhammer esophagus, is a nicely lying, relaxed cat. Compartmentalized pressurization is a crouched cat.
Okay, sir. Next question. For rapid drink challenge and multiple rapid swallows, there is no markers for measurement in our AI. Any specific measure, sir?
I don't know what system they are using.
Mm-hmm.
In the ready stock system, I assume the question is, I want to put it as rapid drink challenge. I want to
Yes.
put it as MRS on
Tag.
the tag. See what I do is, even in the 16 channel system, you have to go into the list of things that you have got there. It is editable.
Mm.
You ask your technician to come and add multiple rapid swallows, rapid drink challenge. You put bracket 200 ml or 100 ml, you put and keep, they'll be able to do that. Unable
Okay.
to put markers.
Mm. And maybe technical issue, sir. Maybe has to
I
solve
think it's more a
it.
technical issue rather than. So I think your whoever is providing you support,
Got it.
whoever is providing support will be able to add those commands in your drop down box.
Okay, sir. Next question, sir. See, the questions will keep coming. I'll just take one or two more questions. Can IRP be negative? Have gotten a study? If not, where can be the problem during the study?
IRP becoming negative is because the pressure is equal to the esophagus, is equal to the gastric pressure. So you sometimes get negative, or sometimes your cursors have been kept in the wrong place.
No. Okay.
You are above upper esophageal sphincter, below esophageal sphincter. They have been both placed below the esophageal sphincter, lower esophageal sphincter, then you get negative value. If you get that type of negative value, try to move the upper sphincter a little bit above until you start getting. I have very rarely I have got patients where I got like 0.2, 0.5 like that. But by and large, you will get value single swallows. I mean, you will get like 0.8, 1, all those things you can get in some patients where the LES is very, very weak.
Last two questions, sir. Sir, isobaric point you were mentioning as that white aspect during while we analyze it. What is the importance of it? Where exactly we should put a mark, and what is the significance of this isobaric point, sir?
See, 30, 30 millimeter mercury, 30 millimeter mark. See, the company gives you the isobaric points. The black line is 20.
Hmm.
The white line is 30.
30.
Okay. So at the LES, near the LES, where you want to mark the contractile deceleration point, it is done at the 20 mark. Black point.
Black point.
So that black point has to point the imaginary line in the direction of the bolus and an imaginary line from the LES cutting across. So where these two meet, you put the mark at at one of the black point, 20 millimeters. The DCI is measured by keeping around at the 30. That is not important. You are going to take DCI in segment 2 and 3. Full stop. So
Okay.
don't worry about 30 millimeter and all those. Whatever millimeter is there, only it is measuring. No,
Correct.
it is it is millimeter mercury by seconds by centimeters. So it is a composite of all these things. It is a composite of the force, the duration, and the distance. So that doesn't matter.
So last question. You had said that since last 12 years, you are doing procedures which are more physiological. So you start with the sitting position and you start off, you have been doing this for quite a long time. So from water, you have gone to idli, but why specifically not idli with chutney or
See,
sambar?
no. The thing is, I want a solid bowler which is coarse. I don't want the bowlers to become mash. It becomes semi solid. No, once you allow patients to mix it with things, they make it. Whereas this will be solid. The saliva is there in the mouth. The saliva is going to mix it up. It is mashing
Okay.
it. And
Okay.
also with chutney, sambar, all those things, you are adding spices. You are going to add, there is going to be chili, there is going to be some other thing, right? So
Correct.
we do not know how they are going to affect the esophagus and it's working. Whereas a plain idli does not contain any spices. It is only rice and dal.
Okay. There's nothing like some particles might go block the water perfusion system or something like that, sir.
You can ask Narayanan how many catheters he has supplied to me in this last 12 years. He is very upset with me.
Maybe with chutney and sambar, maybe we
No, because water is constantly
constantly
perfusing,
flowing out.
no.
Mm,
And what I generally do at the end of that 10 swallows, I give them 20 ml of water, ask them to rinse their mouth nicely and swallow it.
okay.
So that what is there in the mouth and throat will go, and also another 20 ml after that, just swallow. So that it washes down whatever is there in the esophagus. And when I started doing sitting postures, I have made poster presentations from 2013, 14 onwards about sitting bowlers in GERD, dysphagia, everything. People used to come and ask me, "Oh, this is water perfused. How sitting you will be able to get the same pressure? The pressure will change. All you do is keep your table and your chair so that the patient chest will be at the same level as your transducer.
Mm,
So your hospital cot will be at the level of the transducer. You put a chair by the side of the patient, by the side of the cot. So when the patient is sitting up, his chest will be at the level of the transducer. And always when you change position, make sure you set baseline again.
again, baseline again. Okay. Sir, anytime has it ever happened that in sitting you got a diagnosis and then in supine it was not there, or
Many times, you get differences.
yes, sir.
You get differences. There have been situations where I got absent contractility in one posture and ineffective motility in one posture. Sometimes the patient is tachycardic. I got too many artifacts. I changed the position. I got good reading.
Got
And
it.
anyway, Chicago 4 mandates unless you got achillessia in the primary position, you must do both.
Correct. True. So great, sir. Thank you. If we keep going, there'll be multiple questions that keeps coming because it's such an interesting branch and we have such an interesting speaker today with us. But then we will also call you for a few other talks in future, which again, already have topics in my mind. So we will be seeing you again and again some of the other months, sir. Thank you for all the time you have taken on a Sunday evening for all of us who are enthusiastic in motility sciences. Thank you, sir. It's our pleasure having you. Heartfelt
Thank you,
feelings. Thank you, sir.
thank you. And I hope everyone practices manometry the way it should be. Give time. If you do not have time to give, Do not say it is not my cup of tea, but please do justice to it. I do not do ERCPs. I do not do EUS. I do not do third space. And I do not feel ashamed by saying that. I tell my patients when they come to me and I diagnose achalasia and I tell them my colleague will do. They say, sir, will you not do? I say, no, I don't do. He does. There's nothing wrong. We cannot all do everything. But whatever we do, we must do it properly. We must be good at it. I think that is the most important thing. After all, we are a close-knit community. I'm sure the same in Bangalore also. In Chennai, we all know each other. In the entire Tamil Nadu, almost all of us know every other gastroenterologist. So we all have to have good practice. We all have to thrive. So why we have to compete? Why everyone should do everything? Let us compartmentalize. Let us take areas which is our specialization, and each of us does well in our area.
Point well taken, sir. Now, I think the future is diversification and team practice, where each of us will be specializing in something of their interest. Because of late, once we start doing many things, we realize that we are good at something, we are not so good at something. We have a friend who can fill our gap, and the time has come, sir. So we are at the cusp of that time. So definitely, you would be seeing more of a juniors team where people are getting specialized, and even the data will be much more crisp, and justice is done to the patient also. And few people like you have taken it quite ahead of all of us, much before in time also. That's great news for us to emulate you as a role model. And I am your fan, sir. Thank you. Thank you.
Thank you. Thank you. Have a nice weekend, whatever is left of it. Hope I have not upset your families.
Nothing, sir. Thank you, sir. It's our pleasure to have you here. Thank you, sir. Have a nice day.
Thank you. Bye.
Bye, sir. Bye.